Hey everyone, welcome to yet another webinar of CIMS-JIC 2020. We have with us today two eminent speakers, first of which is Dr. Bhavesh Thakkar. He is a gastroenterologist, hepatologist and endoscopist at CIMS Hospital Ahmedabad. He has done his MD Medicine from Gujarat University and DNB Gastroenterology from Apollo Hospital, Chennai. He has also received Dr. S.K. Sama Gold Medal in DNB Gastroenterology. Moving forward, we have with us Dr. Abhinav Jain, who is again a gastroenterologist, hepatologist, and endoscopist at CIMS Hospital, Ahmedabad. Dr. Abhinav Jain has done his MD Medicine from BGMC Ahmedabad and from KEM Hospital, Mumbai. He is also a gold medalist in DM gastroenterology. His areas of interest are functional gastrointestinal diseases, GERD, viral hepatitis, vascular disease of liver, constipation, and inflammatory bowel disease. Thank you for joining us today, Dr. Jain and Dr. Thakkar.
Thank you.
So now I will hand it over to Dr. Thakkar to give an overview of the two lectures.
Yeah. Good evening, friends. Today we have two lectures. First one is on fatty liver disease. That is specifically non-alcoholic fatty liver disease. Recently, there was a publication on that. Name has been changed from non-alcoholic fatty liver disease to metabolic associated fatty liver disease, because it is all related to metabolic syndrome. So we are going to deal with that non-alcoholic fatty liver disease in first lecture, and second lecture is on endoscopic ultrasound. It is a newer technology being practiced for long time now in India. So what are the advantages of endoscopic ultrasound in GI tract, and how it can be helpful in various clinical situations? We are going to have that two lectures on at present. Thank you.
I'm sure that at least 50 to 60% among us may have fatty liver disease, and this presentation will be on that, how to deal with that, and should we worry, we should not worry, or we should do anything or not. So, what is non-alcoholic fatty liver disease? It is a spectrum. Benign steatosis to non-alcoholic fatty liver, steatohepatitis, then fibrosis leading to cirrhosis, and even hepatocellular malignancy. If we see, when we tell it is a excess of fat is there, when hepatocytes containing more than 5%, average volume more than 5% of fat is there in the liver associated with insulin resistance, it is called as a non-alcoholic fatty liver disease. And we need to exclude secondary causes because they are treatable, like alcohol and others. Non-alcoholic fatty liver disease is a pure steatosis with minimal lobular inflammation without any risk. And concern is about non-alcoholic steatohepatitis. This can be early, fibrotic or cirrhotic. This F0, F1, that is a fibrosis grade based on elastography or based on histopathology. Fibrotic more than F2, F3 is significant, and F4 is a cirrhosis, and they can lead to cirrhosis and hepatocellular cancer. If you see prevalence and incidence data, NAFLD is the most common liver disorder affecting 17 to 46% of the adults, and it parallels with the metabolic syndrome and its components. And 7% of the lean individual may have fatty liver disease, that is a leanness, and they are more complicated, they are more difficult to treat cases. And in India, population-based data suggests that average prevalence is 9 to 35%. And this is a natural history of non-alcoholic fatty liver disease. Many times we have a concern, should we worry? This is over a period of 8 to 13 years. Simple benign steatosis and then non-alcoholic steatohepatitis can progress to cirrhosis, even SCC, and may need transplantation. We'll go with the cases. There's a young 30-year age male who had some abdominal issue, and he was asked to do ultrasound abdomen. Primary treatment was sorted out by primary physician, and then he came to me. That is, USG abdomen is showing fatty liver. What should he do? Should we worry or not? On reading USG report, parenchyma was normal portal vein and splenic vein with normal spleen. This specifically because to see whether portal hypertension is there or not, and there is no history of any long-term medication use or alcohol use. How to proceed? Should we worry or not? That is a question. Now, in this scenario, we need basic tests. They are the like BMI. What is the BMI of the patient? That is 24. He's a non-obese guy, less than 25 with liver function test, hepatitis B, C, and lipid profile. These are the basic parameters that we need. His liver function tests were normal. Hepatitis B and C was non-reactive, including lipid profile was normal. HbA1c was done. That was 5.8. Conclusion: benign fatty liver disease, benign hepatic steatosis, non-harmful steatosis. What should we do? Medication. There is no need of any medication. If he is worried much, we can opt for fibroscan, whether that is showing any abnormality, fibrosis grade is high or not. What is that fibroscan? We'll see it. Now, we should not forget to advise him hepatitis B and A vaccination if he has not done. Another question comes: should we tell patient when should he come again, or when should he meet again or not? Ideally, in such a scenario, 4 to 5 years after, we have to ask to do ultrasound abdomen for that steatosis, whether fatty liver has progressed or not. The benign steatosis. Case 2. He is a 45 years gentleman who has presented with abnormal lab reports, and USG abdomen is showing fatty liver. This is a common scenario that we come across. Fatty liver grade 2 is there, and LFT abnormal on liver function test reports are abnormal. On clinical history, he is not diabetic, not hypertensive. BMI is 32 kilogram per meter square, so he is obese. Now, work profile is a clerk, so most of the time sitting in the office, no physical activity. He's non-smoker. He drinks alcohol, but that alcohol is 5 to 7 drinks per week, not more than 10 drinks a week, and not more than 4 drinks at a stage. So, in short, that alcohol consumption is not more than 30 grams per day. Lab evaluation was showing SGPT was 100, SGOT was 90, alkaline phosphatase of 89, bilirubin normal, proteins were normal. Then comes next test that I already mentioned in first case, USG abdomen, fatty liver grade 2, normal echo texture of liver, normal portal venous system, and normal spleen. What to do further? HbA1c and THCV negative. Lipid profile was definitely, BMI is more obese guy, so lipid profile was as expected, elevated triglycerides, elevated cholesterol, reduced HDL, normal LDL values. HbA1c was again normal. He's a non-diabetic. ANA profile, just for the sake of completion, was done because SGPT and SGOT were more than 2-3 times elevated. So I asked for fibroscan. Fibroscan is a non-invasive method that is it is a almost near complete replacement for the liver biopsy. Fibroscan value was 6.9 kPa, that is borderline. Up to 7 is normal, more than 7 is significant, or more than 15 is definitely cirrhotic. So it was 6.9. So in conclusion, this case, obese, non-diabetic, not a hypertensive, normal viral markers, dyslipidemia, fatty liver grade 2, transaminitis is there, borderline fibroscan value is there. How to proceed? First thing, stop alcohol. Second is diet and lifestyle modification, daily exercise and weight reduction are must. We have to do that. Aim of weight reduction in such a patient is 5 to 7% of baseline body weight. Rate of weight reduction should be 0.5 to 1 kilogram per week. For patients with suspected or biopsy proven NAS, aim should be 7 to 10% of the baseline weight loss in first visit for in first 3 to 6 months duration. Definitely dietary and nutritionist counseling plays a role to reduce the calorie consumption. Review after 3 months, that is 12 weeks duration. After 12 weeks, his SGPT and OT remained abnormal. He lost 7% of the weight, but he remained, reports were abnormal still. He stopped alcohol and exercise was part of life now. It was there. Further management will be, in such a case, intensification of weight loss up to 10%. He was started on statins and with fenofibrate. Drug therapy, here definitely we are tempted to give some medications. So options were UDCA, that is ursodeoxycholic acid. Is there any role? From my perspective, it is a cosmetic value. It doesn't have any effect on fibrosis. Vitamin E, it has a role. One trial is there up to 2 years. You can use it, but we don't know long-term safety. Pioglitazone, he is a non-diabetic, so I will have a question mark in giving that. Saroglitazar, definitely new molecule. It has a value. It gives reduction in fibrosis at certain extent, but more data are still needed to advocate or to be implicated in the guidelines. So no drugs are approved for NAS. No specific therapy can be recommended, only is treatment that we have a weight reduction dietary modification. Case 3 is a 55-year gentleman. He also is the same with lab abnormality and USG abdomen, was fatty liver grade 2, and his BMI is even more high, 35 kilogram per meter square. He is a not alcoholic, he is non-smoker. Lab evaluations were abnormal with normal bilirubin and protein. USG abdomen was fatty liver grade 2 with normal echo texture and normal portal venous system. Viral markers negative, lipid profile was abnormal, was a concern. HbA1c was 8.5, so diabetic control was not a great. His fibroscan value was 8.5, that is of like F2, F3 fibrosis. Conclusion, he is obese, diabetic, normal viral markers, dyslipidemia with fatty liver grade 2 transaminitis and high fibroscan values. It's a basically metabolic syndrome. For him, target will be definitely the first 3 parameters, the diet and lifestyle modification, weight reduction 7 to 10% or even more than 10% by 6 months we have to achieve. Rate of reduction, same 0.5 to 1 kg per week. And the nutritionist counseling, diabetes control needs to be intensified. HbA1c target should be less than 6.5. Additional medication as needed. Review after 12 weeks was advised. Here also, do we need to give any medication specifically targeting to this steatosis? UDCA, as I mentioned, we all prescribe, but it has a cosmetic value. It reduces SGPT, SGOT, but it does not have any fibrosis reduction on long-term studies. Vitamin E, diabetics, I will not prefer vitamin E because it has a potential to create problem. So vitamin E is not advocated. Pioglitazone, yes, it causes weight gain, but pioglitazone is proven to reduce fibrosis, and saroglitaz are definitely yes. Liraglutide, we all know that it reduces weight as well as diabetes control, and it also helps in reducing fibrosis in the liver. So it is advocated. After 12 weeks, SGPT-OT remained abnormal. He lost 7% weight, continued regular exercise. It was advised to go for liver biopsy. We cannot wait much. We need to find out whether we are missing anything else or it is purely NASH. If no improvement in NASH, no reduction in weight after 6 months of pharmacotherapy or lifestyle dietary intervention, we need to consider for bariatric surgery. Treatment, bariatric surgery has a role. We have to consider after 6 months to 1 year trial of dietary, lifestyle and pharmacotherapy. If no improvement is there, we have to consider. Take home messages. All fat in the liver is not a pathological. As our first case, we have benign cases, we have to wait and see. Not all the fatty liver patients need pharmacotherapy. Do not forget to immunize patient of NASH. Dietary and lifestyle modification with weight reduction is must for NAFLD and NASH patients. And NAFLD and NASH can progress to cirrhosis and hepatocellular cancer that can be life-threatening.
First thing, endoscopic ultrasound. Like no, આપણને કોઈને એક રૂમમાં પૂરી દીધા હોય તો we always try કે window ક્યાં છે, બારી ક્યાં છે, જોઈએ બહાર જોવું છે. So gastroenterologist over a period of time using endoscopes, seeing lumen and lumen, they thought, okay, why not to see beyond the lumen? So then it was an endoscopic ultrasound. This brief introduction and history. Endoscopy was first developed in 1911 and flexible endoscopes came in 1932 onwards, and ultrasound came in practice in 1956. So it took almost 25 years to combine both the things, like endoscope and ultrasound probe along with that, and endoscopic ultrasound came in 1980s. What is the advantage? Why endoscopic ultrasound is needed? Because most of the time when you read USG reports, they say pancreas could not be seen due to presence of bowel gas. So this bowel gas interference will go away with the endoscopic ultrasound. That is the greatest advantage, and you can actually see the structures just beside, just putting a scope near to that, only lumen is in between. So luminal layers are there, and you can see beyond that what you want to see wherever endoscope can reach. Now, what are the applications? Like, what is the difference? Here you can see this is a gastroscope I have kept. Is a terminal. It is a looking at the tip of the scope. There are channels and there is a glass and there is a camera and everything. When endoscopic ultrasound comes, this is a radial endoscope and this is a linear endoscope. Two different
different types of endoscopes are there. Here, this is the ultrasound probe, and from here, working channel, and all needles and all instruments can be going through that. So this is the main difference between EUS endoscope and normal gastroscope and colonoscopes. What are the applications? I'll limit my applications to pancreas, but where all it can apply. Starting from mouth, when you go and enter in the esophagus, mediastinal examination can be done. Starting, you can see cardiac valves even, and mediastinal lymphadenopathy examination and tissue acquisition can be done. If you go beyond from G junction, you can visualize pancreas, and from the pancreas, biliary tree, left lobe of the liver, and when you reach duodenum, head and uncinate process of pancreas can also be examined. And another thing you can see with the EUS rectal sphincter examination, like in previous lecture, what is the sphincter status? Whenever there is a post-operative status or post-surgery sphincter laxity is there, we can assess the internal and external sphincter with the help of endoscopic ultrasound. Now, EUS examination for the pancreas, it is, as I mentioned, from G junction, you can see body and tail of pancreas up to splenic hilum. You can examine all splenic hilum up till that. And duodenal bulb, you can see head and genu of the pancreas and second part of duodenum. Examination of the head and uncinate process. Along with that, vasculatures near to that, biliary and pancreatic ductal system can be assessed with the EUS. I'll go through that theoretical little bit, and then one interesting case. In acute pancreatitis, we always have, whenever we are suspecting biliary acute pancreatitis, what does it make difference with the endoscopic ultrasound? These are the study. It is a high specificity to detect microliths and choledocholithesis, bile ductal stones. If you go and see within 24 hours, if you can see lower end of esophagus whether stones are there or not, you can exclude that there is no stone, or there is a stone, there is need of ERCP, or there is no need of ERCP. That can be judged with 98% specificity. There EUS makes a difference. Another comes recurrent acute pancreatitis. Many a time you all come across that there is a second episode of pancreatitis, third episode of pancreatitis. Whether it is going to go on or what are we missing anything after common blood evaluation? About 20 to 30% of patients have idiopathic and they run the risk of recurrent episodes. In that cases, EUS is the diagnostic tool that can help to diagnose sludge or biliary microlithiasis, and with that we can help to manage patients. And it has 96% sensitivity to diagnose gallstones and microlithiasis. So in recurrent acute pancreatitis, when we are suspecting microlithiasis, we have to do EUS and it will help. But when to do that? Usually after 6 to 8 weeks of acute pancreatitis episode, we have to see, because otherwise we can overdiagnose changes of chronic pancreatitis. And EUS and MRCP combined can help to diagnose up to 50% of the cases of idiopathic acute pancreatitis. In chronic pancreatitis, EUS can detect very early changes of chronic pancreatitis where other modalities miss out. And there are specific set of criteria like parenchymal and ductal changes with that we observe in the pancreas. Like on if we see parenchymal changes, hyperechoic foci will be there, hyperechoic strains will be there, lobularity, cyst, side ductal changes, there will be calcification within the pancreas. All that can be studied and that can be confirmed with the help of EUS. Here, this is a picture showing classical EUS picture of pancreatic duct with pancreatic parenchyma and multiple changes. We can examine and we can study that. Along with that, EUS elastography. Elastography is a new modality along with EUS that can detect, based on that strain ratio, we can detect whether chronic pancreatitis malignancy is there or not. It is a specific application of that. In chronic pancreatitis, complications of chronic pancreatitis like biliary obstruction, pseudocyst formation, pseudoaneurysm formation, or development of mass lesion with the inflammatory changes of chronic pancreatitis, we can differentiate. We can do FNA examination and we can find out whether it is a changes of chronic pancreatitis or there is a malignancy. the main change that has happened with the help of EUS is the pseudocyst drainage. Here we can puncture pseudocyst, we can do drainage, and that can be done as a daycare procedure, and patient can be discharged within 24 hours and without any incision, without any need of major surgery. Along with that, like pseudocyst drainage, we can do walled off pancreatic necrosis when patients are critically ill in ICU settings. Metal stent that can be placed from the gastric body or from the duodenum into the large collection, and that can drain out. We can control sepsis, and that can help to improve the patient. This can be done non-invasively without any operative major risk. Another great advantage of EUS is that celiac plexus neurolysis or block that can be done for the pain relief in a patient with chronic pancreatitis or pancreatic malignancy. And there are data that said CT guided or USG guided. If we compare with the EUS always is superior to have a celiac plexus neurolysis will be done very well better with good success rate, and that will relieve the pain for longer extent. We can diagnose pancreatic cystic lesion many a time because nowadays CT scan is so common that incidentally pancreatic cysts are being detected in 2.4 to 13% of the cases, and in that cases evaluation of cystic lesion, whether they are benign cyst or they are cystic neoplasm, that can be differentiated based on the EUS. We can aspirate the cystic fluid, and we can even send that fluid for CE and amylase level to differentiate whether benign lesions are there or malignant lesions are there. Pancreatic mass lesion, definitely major thing is there. In that case, is FNA can be done where because of major vascularity, because of major vascular structures are near the pancreas, we can do EUS guided without any risk and without any complication, and that can detect whether it is a pancreatic adenocarcinoma, neuroendocrine tumors, or other neoplasms. And EUS elastography that I mentioned, and EUS elastography measures the relative stiffness of the tissue by producing color pattern superimposed on B mode image. Like here, that blue is a hard tissue, and that can detect that it is a hard tissue and maybe tumor. We can target that lesion. We can do FNA examination from that lesion. Over and above that, EUS guided treatment for pancreatic tumors, like it is still not in clinical practice, but many centers have started EUS guided brachytherapy, EUS guided delivery of the ablative therapy, and even ethanol injection can be done for the reducing size of tumor or controlling of that. This was the basic where EUS can help us to differentiate where we can have a tissue acquisition. This I have kept a single case. 46-year male, chronic smoker, not alcoholic, with a history of episode of mild upper abdominal pain and dyspnea on exertion on and off for 2 months duration. On evaluation, he was found to have gross right-sided pleural effusion and collapse of the lung. A right-sided pleural effusion with collapse of the lung, and he lost almost 8 kg weight in 1 month duration. And with that, this was the CT scan image done elsewhere, showing gross right-sided pleural effusion with collapse, where he underwent pleural fluid analysis. Pleural fluid was showing total cells of 850 with 70% lymphocyte, 20% polymorph, 10% other cell. He was empirically started on ATT because it was recurrently accumulating multiple times. Pleural tapping was done, and ATT was started. ATT, he didn't respond. He didn't respond within 2 months of ATT. So pleural thoracoscopy was done and pleural biopsy was done. And culture was also sent on the first examiner's culture, grew atypical mycobacteria. That was Mycobacterium porcinum. And pleural biopsy was suggestive of lymphocytic infiltration, plasma cells, histiocyte, and ill-defined epithelioid cells. Based on that, ATT was modified to non-tuberculous mycobacteria. And patient was planned for ICD insertion. But somehow patient was not happy. His symptoms were not improving. He was losing weight and he was not improving. So he came here at the CIMS, where we planned again to do a CT scan, abdomen and chest, both of that, because abdominal pain was also persisting. Lipase on initial evaluation was normal. CBC and all the counts were like typically favoring inflammatory pathogenesis. And CT scan here was this one. CT scan abdomen showing large collections here. You can see large collection in the subhepatic region, pancreatic region, and within the pancreas, peripancreatic region.
you can see that just posterior to the stomach wall there is a large collection. It is around 7 centimeter size. That is not great, but it is a 7 centimeter size collection on the posterior to the wall of the stomach, and there is a well formed wall, and that fluid collection was extending up to the mediastinum. Right side of the lung was entirely collapsed because of fluid. Now what to do here? Because considering clinical scenario, patients pleural fluid analysis was done, but one thing was missing was pleural fluid amylase was not sent here. He was started on ATT, multiple time tapping was done. He didn't respond to ATT. There were minimal changes of pancreatitis with pancreatic fluid collection, and surrounding the pancreas there was a lot of collection and inflammation was there. So we planned for EUS guided drainage, and this was the cyst from the stomach. We can see from the stomach we puncture through the needle, and EUS guided pseudocyst drainage was done. And if you will be surprised to see after 2 months of pseudocyst drainage, this was his CT scan. So this is how EUS non-invasively can improve the patient, and this was actually a cystic fluid amylase level we sent after aspirating pseudosis that was more than 1 lakh. So it was actually a chronic pancreatitis developing pseudosis. That fluid was going above into the mediastinum entirely and reaching up to the right side pleural cavity. Most of the time we see that there is a collection on the left side, pleural effusion on the left side whenever there is a changes of pancreatitis. Here that was the different, and that led to multiple times pleural tapping and all that. And one thing that missed initial investigation was the abdomen was not evaluated at any time. So take home message is EUS is an excellent tool of diagnostic and therapeutic help. EUS has excellent specificity to rule out biliary microlithiasis, stones, and whenever we are suspecting biliary pancreatitis. EUS helps in etiological diagnosis in 30% cases of recurrent acute pancreatitis. For pancreatic pseudocyst and walled of pancreatic necrosis drainage, whenever they are within the reach of GI lumen, EUS is the best tool, and EUS FNA can differentiate benign lesions from malignant lesions. Thank you.
So let us start with the questions, Dr. Bhavesh.
Yeah, we will answer one by one. First question, that is like discussion on steatoria. See, if I answer steatoria is out of construct here, but steatoria is excessive fat in stool that is typically detected qualitatively and quantitatively. Steatoria has no relation with fatty liver disease at present, or nothing worrisome in that. So steatoria is excess amount of fat when patient is taking more than 100 grams of fat per day and 72 hours stool fat. If contains more than 7 grams of fat, then it is a steatoria. On the question, obesity treatment should be done first or last? Abhinav, you can answer that.
Yes, so obesity is the central theme in patients with NASH. And just like metabolic syndrome, central obesity is more important than generalized obesity. And since this is the root cause, I think the obesity treatment should be done first, and we advise lifestyle modification to all the patients with fatty liver disease, whether they are just simple steatosis or they are having NASH. This is the cornerstone of the treatment of NASH.
Just to add in that, the many a time we prescribe medicine, so patient take it lightly that we are taking medicine and that fatty liver transaminitis will improve. So ideally, mild steatosis, fatty liver, we have to intensify that dietary and lifestyle modifications are the only treatment. Don't go for medicine on the straightforward. Okay. Third question, role of history taking in diagnosing NAFLD. How far is it followed in India? See, our center, we follow history taking definitely. Any clinician who is practicing has to do history taking, and history taking plays a major role in that, because the word non-alcoholic, that means patient's alcohol consumption has to be less. It is less than 30 grams per day, or not more than 21 packs per week for male, and more than 14 packs per week for female. So if it is not meeting that criteria of alcohol consumption, then only it is non-alcoholic fatty liver disease. So we have to have proper history taking, that is necessary. Yes.
So the next question is, how long does it take for hepatic steatosis to develop into liver cirrhosis in non-alcoholic patients? So, as per the natural history of NASH, the progression from no fibrosis to mild fibrosis, that is F1, F2, F3 to F4, which is cirrhosis, the progression of one stage can take anything between 5 years to 7 years, and the progression from non-cirrhotic to cirrhotic can take anything between 20 years or 30 years also. About 10% of patients are what we call as rapid progressors, who develop fibrosis very rapidly. And in these patients, the transition can happen within a period of 10 years. And it is not predicted who will be this rapid progressor and who will be the non-progressors. And often when the patient comes to us, we don't know how many years they have already spent, because many times NASH patients, they do not have any symptoms. So it is a very slow process, but in 10% of patients, there can be rapid progression.
Yeah, agree. Next question is, what is the importance of Madrid discriminant fraction score in determining severity of liver disease? See, MDF, that is discriminant fraction, is only for acute alcoholic hepatitis. If that MDF score is more than 32, then patient's mortality in current admission is high, that will be 30 to 40%. So we definitely, in a patient who comes with the alcoholic hepatitis, we have to calculate that score, and that will help in guiding that score. If more than 32, we have to consider for steroid after ruling out sepsis, ruling out any infection. So that is the role. Severity of liver disease can be assessed by child pug scoring system or MELD sodium scoring system. MDF is specifically for alcoholic hepatitis. And next question is, how many patients of NASH develop cirrhosis? That already Abhinav has answered. I'll go ahead with that.
Yes.
Yeah, Abhinav, you can answer. What is the role of elastography in patients with pancreatitis?
Yes. So elastography can be added on to endoscopic ultrasound imaging, and elastography will basically give the information about the stiffness of the pancreatic tissue. Often when we have a mass and we have a doubt whether it could be a malignant mass, or it could be inflammatory mass, or it could be something else, it could be a nodal mass. So in this patient, we can do an elastography. We can know if it is very hard, then it is likely to be a malignancy. We can also, it can also help us to select which areas to focus our biopsy on.
Okay. And next question is your views on pancreatic pleural fistula. As I mentioned in the EUS lecture, pancreatico-pleural fistulas can happen. We need to find out whether there is a fistula and recurrent collection is there or not. Most of the time it happens on the left side. And in that cases, we have to make sure that ductal disruption is there or not. If pancreatic pleural fistula is there and surrounding inflammation is less, some many a time pancreatic duct sphincterotomy and putting a stent will heal the fistula and will reduce the pancreatic fistula will heal, and pleural effusion collection will reduce, and we can remove the stent. Maybe we can restent and remove after a 3 to 6 months period of time, and that can be followed. But it is treatable endoscopically very well. If like in my case there was a large collection in peripancreatic region and pseudocyst was there. If such a thing is there, we can drain pseudocyst and we can collection in pleural cavity will be reduced. Next question is, can we use SGLT R in non-diabetic NAFLD patients? Abhinav, you can answer that.
So SGLT2 inhibitors have been used more in NASH with diabetes mellitus type 2. In non-diabetic NAFLD, I have personally not used this, and I don't think the literature is supporting its use.
Yeah, definitely. I will not use in non-diabetic patients. Is there any new promising medication in pipeline for NAFLD, particularly NAS? Yes, there is a recent data on OCA, that is obeticholic acid, but I will say still there is a time to generalize that statement that we can use that. Presently, only for cholestatic liver disease (PBC) it is advocated to use. I'll also say that in primary biliary cirrhosis, in low doses, we can use obeticholic acid, but as of now, we don't have any promising medication. Yeah. And next question to Abhinav: can we use vitamin E in NAFLD patients? What is your experience, Abhinav? You can share that answer.
Yes, so vitamin E is used in patients with NASH. Its main is that it's an antioxidant, but caution it is not used in patients who already have developed cirrhosis and in patients with diabetes. And for vitamin E for long-term use, again, I would like to caution that there is a risk of bladder and prostate problems and a slightly high risk of non-hemorrhagic stroke. So, but it is in general very safe, and I think it's a good. Even it can be combined with other drugs to have
Yeah.
a.
Thank you. No more questions. Thank you. Thank you all. Thank you,
Thank
Abhinav.
you. Thank you.
And with this, we conclude the session. Thank you.